I'm Dr. Erica Bove, and welcome to the Love and Science podcast. I'm your host, and also the founder of Love and Science, Thriving Through Infertility. I'm so excited you're here today. With over a decade of experience helping thousands of women just like you, I empower professional women to build their families with confidence and compassion. Let's dive in. I wanted to share another story about a dear client of mine who came to me with a diagnosis of recurrent pregnancy loss. She had actually been very proactive, a surgeon. She had frozen her eggs in her 30s, and then she met her husband. They tried to get pregnant. They had 2 losses outside of IVF in her late 30s. And then they decided to try and use the frozen eggs, right? Because they were from her much younger body back then. We created embryos with her husband's sperm. And then unfortunately, they had another loss, which was an IVF tested embryo pregnancy. Then she joined Love and Science. We looked at everything historically in her situation. At this point, she was really starting to feel threatened that she was just going to continue having losses and that things weren't going to work for her. And she ended up conceiving on her next frozen embryo transfer. I will say, after we looked at everything and between her REI, and we decided that Lovenox might be beneficial because her family history suggested that. If you're actually curious, we recorded a whole podcast episode about her story. But just to say that we made sure that the science was sound, we helped her believe that it was possible for her next transfer to be successful. And then would you believe that one embryo split into identical twins, and she went on to deliver 2 beautiful girls? In a way, obviously pregnancy was a little stressful because it was a high-risk pregnancy. Even with one embryo, you can still have a chance of twins. But she did amazingly well. And I think it was really the mindset and the science which helped to bridge her to a successful outcome. I will say, when people have had losses and they say, oh, I just need to get tested embryos, and then they have a euplate transfer and it's either a non-pregnancy or a loss, I think that can be really, really unsettling and truly devastating because it's like, when is this going to work for me? Am I ever going to become a parent? But she stayed with it. She stayed strong. She left open the possibility that it could happen, and it happened in her first transfer after working with me, which I will say is a pattern. This isn't the case for every single person who comes to Love and Science, but many, many people come to me with really long journeys, and then we get everything set, and then their next transfer works. Again, why do we believe this? I'm not sure. Maybe it's another set of eyes. Maybe it's physiological regulation. Maybe it's making sure all the science checks out. Maybe it's having support and the physiology, relaxes from hypervigilance to one of receptivity. And that's what ultimately helps people, bridge to parenthood. Again, I can't prove exactly what's happening, but what I will say is that when I see the energy shift, when I can take on the burden of, the whole journey and my physician clients don't have to worry, that's when we see the successful outcomes. So again, you can go and listen to her whole podcast because we recorded a whole podcast episode about her journey and what Love and Science meant to her. But if you're in this situation where you've had recurrent loss and you keep having losses, even despite IVF, maybe even tested embryos, let's have a chat because I still believe there's hope in your situation. I love you. Bye. Hello, my loves, and welcome back to the Love and Science podcast. Today, I'm going to talk about something which is really important, which is my paradigm for helping people work through their treatment options. I will say this is one of the hardest things that I do. I mean, it's not hard for me anymore, but it's one of the hardest decisions that my patients and clients can make because sometimes we can get so caught up with the right decision instead of making a decision, try that for 3 months. If that doesn't work, move forward with something else. I think that we can get into this analysis paralysis, like I like to say, and we can get down the Reddit thread and we can get down the PubMed rabbit hole. And I can tell you what the American Society of Reproductive Medicine recommends for various things. I also have adapted my own art and science of medicine as well, because, when you have done this for so long and you've helped people, I really do think that the framework that I have, adopted over time and refined is working for my patients and my clients. So I'm very proud about that. But I think it, it sort of depends on each person and each couple There are no two patients or couples who are the same, and every single treatment plan needs to be interpreted in light of people's family building goals. So I really want to start there and say that, like, you can read ASRM's documents, you can look at the data and all those things, and that is very important to do. We have to make evidence-based decisions. And by the same token, sometimes there are other factors which come into play. Like, for instance, say somebody who has a sister with infertility and they got pregnant a certain way and they have very similar situations. Say somebody, their labs look okay, but their mother went through primary ovarian insufficiency, and maybe we don't think we have quite as much time as somebody else without that family history. Say somebody has ovulatory PCOS and they've been told, oh, it's okay, you just need to keep trying. And I know in my bones that if we give them a whiff of letrozole, that's probably going to help their choreography of their ovulation. Like, these are the nuances that I've learned over time, and that's what I'm hoping to share. Okay, so everything starts with the history. So I hope you and your REI get to have a long, thorough discussion when you first meet about who you are, what you've been through, your medical history, your GYN history. If you have a male partner or maybe a female partner, if you're doing reciprocal IVF or something similar, trying to figure out your order of operations, like the history of each person in a dyad is very important. What am I thinking about when I see somebody for the first time, right? So first I want to understand like who they are and what makes them tick, and when they met their partner, if they have a partner, how long they've been trying, if they've been trying. All those different things are really important, and how many children they're hoping to have. Because this is another key point, is there is no treatment plan that makes sense unless it takes into account somebody's family building goals. I'm going to say that again. There is no treatment plan that makes sense unless it's interpreted in light of somebody's family building goals. So if I see somebody and they are 34 years old and they want, say, 4 children, I will treat them very differently than if I see somebody at 34 years old and they desire 1 healthy child. Those are very different situations. So again, understanding in an ideal world how many children somebody would have, I think that is really, really important. I see notes all the time where people don't even ask that question, or maybe they do and they don't document it. This is one of the most important questions. And people might say, you know what, I'm beaten down. Initially, we wanted 4 or 5 children, and now we just be happy with 1. I understand that goals change over time, expectations change over time. But what I'm really saying is, like, I'm not just here to cobble together some sort of a plan for you because this has been rough for so long. I really want to know, in your ideal life, what does this look like for you? And maybe we might get to that desired family size through a blend of different treatment options. Sometimes people build their families in very creative ways. There's always a way. But again, I don't want you to shrink yourself and your goals just because up until now things haven't been successful. And I think that's really important to acknowledge. Okay, so I want to know, how long have you been trying? And not necessarily how long have you been trying in air quotes, but how long have you been having unprotected sex, in general? And so sometimes people say, well, we took out the IUD, but we weren't really religiously trying or doing it on a schedule. Like, it still matters. If you were getting together with your partner with some degree of regularity, like, that matters. Like, if you're getting together about twice a week, there should always be sperm there. Again, assuming a heterosexual couple, I understand that there are many people who see me who need donor sperm for same-sex couple reasons, single parenthood, procreation, maybe severe male factor. Like, I understand there's those sorts of things, but I really want to know, how long has there been sperm and egg exposure, not just how long have you been trying on the calendar. And I get it. Like, maybe you and your partner were in different training programs in different cities. Like, that's obviously a factor as well. But the whole picture matters, right? I think oftentimes people say, oh, we've been trying for a year and a half, but maybe no birth control for 8 years. That whole history is really important. I also am listening as I listen to your story to understand, are there any risk factors for infertility? Are there any things that raise my eyebrows that make me think that it might be harder for you? So, one of the big things is risk factors for a tubal factor, right? Because if the sperm and the egg need to meet each other, right? I think of the highways, the tubes are the highways for the sperm on the way up and the embryo on the way down. And so if we have transport issues, that's a situation that's going to make me think, more about in vitro fertilization from the very beginning. And, again, never say never. I've seen people conceive in situations that I thought were highly unlikely based on imaging, but depends on people's goals and their risk tolerance. That piece of information about fallopian tube patency and also risk factors for fallopian, tube disease function really, really important. So like if somebody has a history of, say, Crohn's or ulcerative colitis, or maybe they've had multiple abdominal surgeries, or maybe they had pelvic inflammatory disease when they were 20 and were hospitalized with IV antibiotics. I've even had people with like ciliary dyskinesia. We know there's cilia in the fallopian tubes.
Hello, my loves. I am so excited to share this news with you. If you are a female physician navigating the fertility journey and you want a structured, evidence-based plan, I have created a free resource for you. It's called the Physician Fertility Roadmap. I have created a guide to help you optimize your chances of pregnancy and a successful outcome over the next 6 to 12 months. Check out the link in the show notes. Love you. Bye.
Maybe somebody is working really hard to quit smoking, but they haven't been able to do that yet. Like there's all sorts of different reasons why I might think about fallopian tube disease. Maybe somebody has comes with a diagnosis of endometriosis. Maybe somebody has a history of an ectopic pregnancy. These are all things that, even severe pelvic pain where I'm like, okay, they don't have a diagnosis of endometriosis, but it sounds like they very well might based on their symptoms. Like those are all things that factor into like, is this person or couple going to conceive outside of IVF, or should we be thinking about accelerating to the IVF pathway? I'm also thinking about risk factors for other fertility diagnoses, like, does it sound like this person's ovulating regularly? If somebody's having regular cycles, it's usually pretty likely that they are ovulating. But if they have, say, ovulatory PCOS, where they have a bunch of acne or extra hair, or maybe lean PCO, and maybe their LH function isn't optimal, those are reasons why it might make sense to, add a little bit of, say, letrozole in the mix to help improve the ovulation. So I'm always thinking about, okay, does this person have regular cycles? Do I think that they're ovulating? Do I think that this person is having a fair chance at sperm and egg exposure every month? Because if they're not, then that's where my interventions might make sense a little bit sooner. So thinking about risk factors for ovulatory dysfunction. Maybe somebody says, oh, my mom needed to take Clomid to conceive me. That's always a ding, ding, ding. Okay, there's a 50% chance that you, my friend, have PCOS in front of me. Or if somebody's sister had PCOS, same thing. First degree relative, 50% chance they have PCO. And so I'm thinking more about going down that pathway. Similarly, like any sort of cancer therapy, any chemotherapy, radiation to the pelvis, there's all sorts of situations where people can have iatrogenic reasons to have, fertility issues. Maybe somebody had an ovarian cystectomy and they're, missing a large part of one of their ovaries. That's all relevant data. Say, I have patients and clients who've had a history of testicular cancer. That's also really relevant information. And so, we say, okay, well, if you're under the age of 35, try for a year. If you're 35 or over, try for 6 months before seeing a fertility specialist. It's interesting that the difference in success rates between people who try for 6 months and a year under the age of 35 is really only 5%. So I always say if you're anxious about it and, it takes a little bit of time to get in to see somebody like me, an REI, then just book the appointment on the sooner side. And hey, if you get pregnant in the meantime, guess what? You just cancel that appointment. So again, I'm always listening for risk factors because if I think that there might be something, male factor infertility, say I'm seeing somebody who had 2 children and then got divorced and then has been unable to conceive with her male partner, and he has tried in 2 prior relationships and has been unable to conceive. Again, you start to kind of like think in terms of like, hey, what's the missing link here? Where are things not connecting? And then again, I can't stress enough the desired family size. Like, again, I'm always thinking in terms of, okay, who is this person or couple in front of me and what sort of a family do they desire? Some people say, you know what, Dr. Bove, I've always wanted to adopt. I'd like to have one adopted child at least in the mix here, but I also think I want a child who's biologically linked to me. And so there's all these different ways to think about it, but I always like to know, like in your desired family, like what does that look like? What components and what do we need to start thinking about today? We know that adoption takes time. We know that other family building methods take time. And so how can we do things in parallel instead of series to bridge people to their desired family as soon as possible and with the least amount of suffering possible? Okay. So then we do the evaluation, right? So we need, I take the history, I listen, I try to understand if I think people are ovulating. Sometimes people come in and say, yeah, my ovulation picture kits go from negative to positive mid-cycle. That sounds pretty encouraging. We get the labs, which I have full podcast episodes about what I like to get, but I usually will get some sort of ovarian reserve assessment. So anti-Mullerian hormone, which can be done at any point in the cycle. I love to catch people on day 2, 3, or 4 of their menstrual cycle, day 1 being the first day of true flow, to get the follicle stimulating hormone, the estrogen. I like to get a luteinizing hormone. I see so many female physicians with a little touch of hypothalamic amenorrhea, and that becomes relevant later when we're thinking about IVF, if we are thinking about IVF. So again, I usually add an LH on, and anybody who I've talked to for at least 5 minutes, REI-wise, sees the beauty in the reasoning and, is usually convinced. So I think that's always a good thing to add on. We talk about, I know thyroid has gotten more controversial over the last year with the new ASRM guideline. I have a whole podcast episode on that as well. But, there's usually a reason to check at least a TSH when we first start talking. I don't know any female physician who's not tired, who has at least some symptoms of hypothyroidism. So, that becomes relevant. I also like to get the preconception labs to make sure that people are optimized for a pregnancy. There are certain vaccines that are live vaccines that we can't give when somebody's actually pregnant. So rubella, varicella, measles, those are great examples. And so I want to know if people are immune or not before we start the process of treatment. Other things, uterus and fallopian tubes, I will often start with a sonohysterogram if I think that the, risk factors for fallopian tube disease are pretty low. Gives a really nice comprehensive view of the pelvis. I can get an antral follicle count ultrasound at the same time. I can see the relationship of the ovaries to the uterus. My sonographers are fantastic. And I also go in and do the scan myself, and we can really see if there's a sliding sign, if I think there's any scar tissue. So I really do love the sonohystogram for a nice view of the uterine cavity and also, a view of the fallopian tubes as well. However, if the risk factors are there and there's a high suspicion for fallopian tube disease, I will either start with the hysterosalpingogram, which is the X-ray based test with a little bit of iodine-based contrast, or also do both, because if we get the HSG, the hysterosalpingogram, and we don't get a great view of the cavity, we can miss small lesions in the cavity that might be relevant as we think about treatment. And so again, some sort of anatomical assessment. Typically, I start with the sonohysterogram, which we call the hycosi, which is a little bit of air bubbles to the fallopian tubes. But the risk is that if there is a blockage, sometimes we can look at that image even in real time and say, oh, yeah, there's bubbles. We can see them going through the tubes. And I say that in air quotes. And sometimes it's truly just the turbulence of the bubbles in the tubes and not that actual flash out the fimbriae, the fimbriated end. And so there can be false negatives. We might say, oh, yeah, this is a normal test. But then, in fact, if somebody does have true fallopian tube disease and we don't diagnose it appropriately, that can delay treatment, right? Again, if there's a big brick wall between the sperm and the eggs, then never the two shall meet, then we're doing people a disservice if we don't give them an accurate diagnosis from the beginning. Also, another reason to get an HSG, say you're listening to this podcast and you've had unsuccessful IVF. When people have a hydrosalpinx, which is not always evident on a 2-dimensional ultrasound or a 3D ultrasound, because these things can come and go over time. If somebody has a hydrosalpinx, that actually decreases their chance of success in half. It cuts the success rates in half. So if you have a euploid embryo, your chance of success is 65%, and you have a hydrosalpinx, automatically those success rates get cut in half if you have a hydrosalpinx. We don't know exactly why this is. We think that it is partially because of the toxic chemicals that are in the hydrosalpinx fluid, because those are not good for the uterine environment. There also may be a mechanical flushing effect of the embryos themselves, but it is documented that when you have the hydrosalpinx, your success rates are lower, and then when you remove the hydrosalpinx, then your success rates go back to the baseline. And so, very good reason, especially in the context of unsuccessful IVF, when so many people actually have undiagnosed endometriosis, that we look at the fallopian tubes and think about things in that way. Okay, so also semen analysis. We talked about ovarian reserve assessment and uterine cavity and fallopian tube assessment. Really important to get the male evaluation from the beginning. Up to half of infertility is related to male factor. And so the sooner we can check the male side of the equation, if there is a male side of the equation, the better we can get people shuttled to a reproductive urologist if needed, work on lifestyle changes, maybe bank sperm if the sperm, counts are declining rapidly. There's so many things we can do with the awareness of the sperm component. But if we're in the dark and we don't know what's going on, we actually might do, a 4 to 6 week evaluation for the female, start treatment, do 4 months of treatment for the female, and then 6 months down the road, be like, oh my goodness, there was actually a problem here. And now we're 6 months older and, have nothing to show for it. So I'm a huge proponent. I know it's awkward since COVID. If people live within an hour, we usually will have them collect the sperm sample at home. And, it is what it is. I wish there was a different way to get that information, but it's really useful information to look at the motility and the count and the morphology of the sperm. We use the WHO criteria and say if we think that there's a reasonable chance of somebody conceiving outside of any interventions, which is really useful information to have. Okay, so I think you're hearing that everything starts with a diagnosis.
If you're listening right now and finding yourself nodding along, this is usually the moment people realize that they want support that's specific to them. In addition to this podcast, I offer one-on-one fertility consults where we look at your full picture with both strategy and compassion. You can learn more in the show notes. Now, let's get back to the conversation.
When I make the diagnosis of ovulatory dysfunction, so either somebody is completely anovulatory related to PMOS or hypothalamic amenorrhea or thyroid issues or prolactin issues. Of course, if it's thyroid or prolactin, we try to correct those problems at the source. If it's hypothalamic amenorrhea, sometimes we work on decreasing the physical activity or, maybe some weight gain, some gentle weight gain for people who are super lean. There's those sorts of things. PMOS, which used to be called PCOS, that can be a little trickier. For some people, it's related to, that the fact that they gained weight, but other people, even at normal BMIs, will have ovulatory dysfunction. And so that's definitely a conversation to have. But I think that when I diagnose that, really at any age up until the late 30s, it depends on people's family building goals again, but I'm usually likely to say, hey, you know what? You really have not been having sperm and egg exposure. So let's give your ovaries a nudge. It's a pretty low tech way, pretty well tolerated medication. Most people don't have side effects to letrozole. We help induce follicle development. You and your partner get together when the time is right, when you're ovulating, and then we'll try that for, up to 4 months or so and see if things will connect at that point. Because again, we're correcting the problem at the source. If somebody is not ovulating or ovulating well, and we help that process, sometimes that's enough to get people over the subfertility threshold and to get them on their way. And I've seen people who had their first kids at 37 this way and their second kid at 39 this way. Especially if it's due to PMOS, people tend to have higher AMHs at more advanced ages. And not that fixes the aneuploidy problem, but if it's a lot easier to get to a good egg from many eggs than it is from few eggs. And so people with PMOS do often find that they still have more fertility longer than their counterparts without PMOS. So important to think about if that's what's going on, then, helping people ovulate can be really helpful. If somebody has male factor infertility and it's just purely male factor and the sperm are in the range that they are kind of IUI range, and you've probably heard me talk before about how I put sperm into 3 buckets. There's sperm that, are fine for people to conceive at home. There's sperm that are a little bit abnormal, but not so bad that IVF is needed. If we can concentrate the sperm, we can put them beyond the cervix into the uterus. That is really enough to help get people to their goal. That's kind of IUI or intrauterine insemination range sperm. And then there's sperm that are IVF range. And so sometimes you can actually work with a urologist and get the sperm to kind of improve buckets, like IVF sperm to IUI range sperm. But, it's really nice if I see a couple and they don't want to spend a ton of time with optimization, they want to move forward. An insemination is a very nice way to say, hey, we know that in a typical situation, despite having millions of sperm, only a few hundred get into the cervical mucus, into the uterus, and you have a chance of meeting that egg when it's ovulated. If we know that there's decreased numbers or decreased movement or anything like that, and it seems to be purely male factor, let's get the sperm beyond the cervix into the uterus and get millions of sperm to be able to, approach that egg that's ovulated. And that can really improve people's chances. And so If it is purely male factor, I might even have the female track her menstrual cycle, and then when she's ovulating, come in the next day for an insemination for up to 3 months and just see, and especially if it's somebody who's super young too, I might even extend that to 6 months, because anything I do in the fertility realm in terms of helping people ovulate more eggs or, sometimes even IVF, like those things are going to potentially increase the risk for twins. And we know this is well documented that one healthy baby at a time, singleton pregnancies by far do better than twin pregnancies from a risk standpoint. And so when I see people, I say, my goal is not just to get you pregnant, but I want you to stay pregnant and I want you to walk home with a healthy baby in your arms, in 10 months. And so keeping that as, the goal, not just saying, okay, I did my job, I got you pregnant, but it's triplets. Like that's never the goal. The goal really is to say like healthy mom, healthy baby, like moving on forward. So again, in the face of isolated male factor infertility, oftentimes staying the course, doing the IUI, especially if the sperm are good enough for IUI range, and seeing if that might augment the situation enough to get over that subfertility threshold, that can be very, very worthy. And also, I did briefly touch on lifestyle changes. The caveat is that if a man will make a lifestyle change, it can take actually up to 3 months to see that downstream effect in the sperm because of how long it takes for the sperm to go through the male reproductive tract. And so just wanted to share that, patience, it can be a game of patience. I do actually see a lot of PMOS and male factor, combined. So it's like a mild male factor and mild ovulatory issues. And then the two kind of together keep people subfertile. And so in that situation, I might actually do like letrozole to help the woman ovulate a little better and then time the insemination to that. I can't tell you how many people in my practice I've helped with that combination. And it's not even something I really appreciated until I was an attending how common that combination is. But again, most infertility is not one giant thing. It's usually like a little bit of this, a little bit of that, a little bit of the other, and it keeps people subfertile. Okay, so far we've covered that if somebody's not ovulating or I don't think they're having a good quality ovulation, we will address that with ovulation induction, typically with letrozole, works better than clomiphene. And then if somebody has a male factor component, we will either do like an isolated insemination, tracking it, timing it to the woman's ovulation, or sometimes if it's combined, PMOS, ovulatory dysfunction, and male factor, we can combine those two. So those treatments are very, very low tech, very non-invasive, and people tolerate them pretty well. So that's sort of how I think about those situations. Now, what happens when we move into the realm of unexplained infertility? Or maybe some like mild diminished ovarian reserve, but nothing really else comes up. I see this all the time in female physicians. And I also think we are not the most patient group either. And so sometimes, like I see this all the time, like somebody will say, okay, I've tried for 2 or 3 months. I got my labs checked. My AMH is 0.8. Like, what do I do? And sometimes the right answer in that situation is actually to say, okay, stay the course, try a little bit longer. And if things haven't connected by 6 months, then, maybe think about intervention, because another big theme of this is sometimes less is more. And if you want 5 children and your AMH is 0.8, then by all means, maybe it makes sense to do some embryo banking. But if really your goal is 1 to 2 children and you've been trying for 2 months, we cannot interpret the AMH in the context of not being infertile. And so again, infertility is defined by those thresholds that we mentioned: under 35 trying for a year, 35 or above trying for 6 months. And so really saying, okay, we know that these values don't mean anything outside of the context of infertility. And so trying not to freak out, trying to say, okay, I know I checked this on the early side. I don't know exactly what to do with it. I'm going to lean on my REI, but like, this is not the same as an AMH in somebody with true infertility. Like, I think we have to remember that. So unexplained infertility means that you've had the full evaluation and you've been trying for the designated amount of time, and the anti-mullerian hormone is normal, the ovarian reserve markers are normal, the semen analysis is normal, the uterine cavity is normal, the fallopian tubes are normal. I don't think there's any evidence for endometriosis, although that is a big minefield because there is a lot of overlap between unexplained infertility and endometriosis, because the diagnosis of endometriosis is truly made through surgery. But I think that, if you do get that diagnosis of unexplained infertility, the way that I think about that is, I think about it in the context of family size. So if you are under 35 and you're hoping for 2 or fewer children, I think it's very reasonable to start with controlled ovarian hyperstimulation and inseminations. So, why do we do this? And what is even controlled ovarian hyperstimulation? It's different than ovulation induction. My fellows, I tell this to them until they're blue in the face and make them recite it back to me so they know. Words matter. Ovulation induction is when you're actually trying to induce somebody to ovulate. Okay. It's like either inducing ovulation because they're not ovulating, or ovulation augmentation, which is when somebody has, say, like ovulatory PCOS or maybe oligo ovulation and you're trying to like help them with their cycles. Like that I consider as like the goal is 1 to 2 follicles. Letrozole is usually the first line. Now, when we're thinking about controlled ovarian hyperstimulation, that's when the goal of follicular development is actually 2 to 3 mature size follicles. And mature size follicle is anything that is greater than 14 millimeters in mean diameter. And why does this matter? It matters because if you are undergoing cycles and you are not quote unquote at goal, like if you are if you have unexplained infertility and your doctor is trying to help you with these non-invasive methods and you are making 1 follicle and having an insemination, those cycles only have a 5% chance of success because you're not making 2 to 3 follicles. And so I'm a stickler about this and I want to scream it from the rooftops and I want to empower you with this knowledge as well. If you have unexplained infertility and you are not making 2 to 3 follicles and having an insemination, that is not the standard of care of what we do, right? And the theory is that in unexplained infertility, there might be some egg quality issues. In unexplained infertility, there might be some sperm function issues. And so if you can up the ante on both sides, if you can increase the chances, from what's happening at home, where say there's like 1 egg that's being ovulated and it's an intercourse situation where the sperm that make it in and the rest fall out. Like unexplained infertility means we don't know what's going on, but we know that if we can increase the things on the female side and increase the things on the male side, that goes from a 5% chance per month of just saying, okay, we're going to do, an ovulation, we're going to do controlled ovarian hyperstimulation, or we're going to do an IUI, less than 5% chance of conceiving and without any treatment. But if we combine the controlled ovarian hyperstimulation with the insemination, that chance of success goes actually up to 10 to 15% per month, which is wild. It is amazing that we can improve the chances that month. And, I know to hear those numbers, if it's you, is disheartening, but I like to frame it in terms of like, hey, guess what? When we are the most fertile, we are actually conceiving at the rate of 20% per month. And so if we can get you to 10 to 15% per month, when if you look at the data, you have a less than 5% chance of conceiving on your own, then that really is progress. But the caveat is you have to be at goal. So sometimes people use clomiphene citrate to do this, or Clomid. That is a fine medication. It's very historical. It was like the first thing that we had to be able to do this. I will say for many people, though, the side effect profile is pretty terrible. And so many people describe hot flashes, mood swings, vaginal dryness. Some people even see scotoma. If you see scotoma or spots, please stop the medication immediately. Some people have terrible headaches. It's just a nasty medication to be on. You're not really supposed to be on it if you have migraine with aura. Like all these different things can happen together. There's actually a recent paper in Fertility and Sterility that shows that if you can use letrozole, which is a much gentler medication, and you can get to the goal of 2 to 3 follicles in these controlled ovarian hyperstimulation / IUI cycles, that your success rates are just as good as if you use clomiphene. And so for that reason, I will often use letrozole, higher dose as the first line. And I also like letrozole because it doesn't tend to have such a negative effect on the uterine lining. And so some people too, I will also say if somebody is like 37, 38 and above, and I'm trying to get them to controlled ovarian hyperstimulation, I will often use like a baby dose of FSH as well. Like I will do this hybrid therapy where I give like, say 5 milligrams of letrozole days 3 through 7, and then add in a baby dose of FSH day 7, 8, and 9, bring them back on day 10. This is called hybrid therapy. There's something about older women where they just, and I know say older, but it's relative, like people in their late 30s that just, the body likes a little bit of follicle stimulating hormone. And I understand that this does slightly increase the risk of multiples, but especially once you're talking about somebody who's 38, 39, maybe even 40, it is a very cost-effective way to induce controlled ovarian hyperstimulation without the, oh my gosh, you're on, straight gonadotropins, FSH, LH, like your risk of multiples is 25%. It's a nice way to preserve like a lower risk of multiples and also have a nice chance of success, because what happens basically, if you want to nerd out for a second, is as we give the letrozole, that's an aromatase inhibitor, so it decreases the conversion of testosterone to estradiol. And when that happens through negative feedback, the brain gets activated. The brain pumps out more follicle stimulating hormone, and then that creates the development of follicles. But the whole physiology of the dominant follicle is that it hogs, basically it has the FSH receptors, it expresses the most FSH receptors, and then it starts to hog the FSH. And so then the other follicles kind of start to die out. But what the exogenous FSH does is right at the moment when the dominant follicle is starting to hog all that FSH, it actually makes more FSH around to be able to then affect the other smaller follicles that are in that same cohort. So say you have 3 12-millimeter follicles, and then one starts to become the cream of the crop. What the baby doses of FSH will do is it will start to support those other follicles that would have otherwise been pushed down by the physiological process. And you're much more likely to get a cohort of 2 to 3 follicles, especially in older women. So, people talk all the time, again, this is more the art of medicine. One of my mentors in my fellowship told me, giving oral medications after the age of 40 is like spitting in the wind. And I'm going to clarify, giving oral medications alone after the age of 40 is like spitting in the wind. But again, if you're trying to do a controlled ovarian hyperstimulation cycle with a baby dose of FSH, that can be a very nice way to balance safety and success, as I like to say. Okay, so controlled ovarian hyperstimulation with insemination is a great first line for people who are under the age of 35 with unexplained infertility, who maybe don't want a huge family size, maybe 1 to 2 kids. I will sometimes use that in my 36, 37-year-olds, especially if their ovarian reserve is pretty good and they, are open to, the 10% risk of twins, if there is a risk, if they do this method. And we move on forward, right? If somebody has a unicorn uterus, or they have another reason why, another health condition, like say diabetes or history of preeclampsia, or a reason I really don't want to give them multiple gestation, history of preterm delivery, maybe I might try to go to IVF and put in one high quality embryo. But again, less is more sometimes. And so sometimes we think that IVF is superior, and it really isn't always. And so, thinking about what is the diagnosis, what is the goal, and really using these non-invasive methods. And I'll be honest, there's a lot of female physicians I work with who are very, very scared of aneuploidy. And I understand that as a real, real thing. It's one of those things that we all have to balance. I will also say a lot of people see me, in their mid to late 30s who have already been trying for a whole year, and they're like, oh my gosh, I have to go to IVF to, weed out this risk of aneuploidy. And it's just, okay, mentally speaking, it's okay, does this really make sense? Does it not make sense? You might generate one embryo. We're not really sure that the outcomes are better if we go through the whole rigmarole of PGTA. So again, helping everybody in the context of their situation and understanding that there are really good prenatal testing modalities and tests to help identify aneuploidy on the earlier side. Not that it's anything I would ever want to go through myself. I have gone through it myself, or wish upon anybody. But again, it's all balancing, how are we going to bridge somebody to a successful outcome? And sometimes, again, I'm a huge proponent of IVF, but sometimes keeping things inside the body when it's appropriate in the face of open tubes and normal sperm, that will often get people to their goal sooner with a lot less stress and a lot less to go through. Okay. So say somebody is over the age of 35, or maybe even over the age of 38, and they have unexplained infertility, then you start to wonder, okay, well, do we want to do controlled ovarian hyperstimulation? Do we want to go right to IVF? If somebody comes to see me and they want, at least 2 kids, then I might, sort of say, okay, maybe we start talking about IVF on the sooner side. We know that once you're 40, that the fastest way to conception, both getting pregnant and staying pregnant, is IVF. And so, there is that, but there is that gray zone of people in their late 30s, and that's a very individual decision. Again, I always look at prior history, and if somebody's gotten pregnant outside of IVF, I might, and they've had a successful live birth, that might be somebody that I might, say, hey, you may not need IVF. But if somebody's been trying for a long, long, long time, and they're 38 and they want 1 to 2 children, that's a situation where I might say, you know what, let's think about IVF on the sooner side. Okay. So, when might I recommend IVF from the get-go? That's kind of a nice segue. So if somebody is in their late 30s and they have a large desired family, at least 2 children, sometimes I will recommend going to IVF first to do something called embryo banking. And again, it's not always superior. And I think that's where we female physicians can get into trouble, is our training is so darn long. Maybe we haven't met a partner. And then finally we're starting to try at 38, 39, 40. And our bodies are just not as efficient at that time. And so And sometimes many of us have actually frozen eggs earlier, but we don't want to touch them. I always like to get a nice balanced approach of like, well, what do we actually have to work with? And so I'm also always a proponent of saying, okay, well, you did this egg freezing cycle for a reason. Why don't we thaw your 33-year-old eggs and see what comes out of them? Because, it might reduce the stress to move in that way as well, at least to interpret your current treatment in the context of what you actually have frozen, because it's really hard to extrapolate a certain number of eggs, because they're just eggs, they're not embryos. And it's nice to kind of thaw them, fertilize them if you have a sperm source, grow them out and see what they are, so that you can, in terms of your thinking about assets, you can think about what assets you have already that might help you decide how many cycles to go through at the age that you are. So late 30s and large desired family, maybe move on to, right to IVF. If you have a genetic reason why IVF makes sense, so say you and your partner both came up with the same recessive mutation, or say you have an autosomal dominant condition in your family, you want to do PGTM, say you have a balanced translocation that somebody discovered somewhere along the way, and you want to reduce the risk of miscarriage because you can screen the embryos. Those are all very valid reasons to move right to IVF. But I think that we don't, it's like this scarcity mindset. Like, it's like, oh my gosh, I need 2 to 3 euploid embryos per desired live birth. And, we just get so mired in this scarcity. And then we get all the negative vibration emotions like, helplessness and powerlessness and fear and anxiety and scarcity. And those are not good emotions to have within us if we don't process them and let them go. Those do not welcome an open and receptive state where we believe that this is going to happen for us. And so that's one thing I love to help people with, is to say, okay, first of all, we have to start with an accurate diagnosis. If people even have a diagnosis in the first place, we have to do our due diligence to make sure that we've checked, we've left no stone unturned. And then we use that starting diagnosis and the age of the female partner. The male partner is really not as important. And the desired family size, then we make our best decisions. And then it's some sort of combination of, okay, is this quote unquote just ovulation induction? Do we need to consider an insemination, either for like male factor reasons, or maybe it's controlled ovarian hyperstimulation in the context of, unexplained infertility, or maybe low egg reserve. And then when do we decide to do in vitro fertilization? Do we do it because we want to embryo bank and we know we want a lot of children? Do we do it because of genetic reasons? But again, if you're 32 and just want to go to the most successful thing, I will tell you that sometimes less is more, and IVF is not the best first approach. And so it's always hard to make these sort of statements without knowing you and your particular situation. But what I'm hoping is that by listening to me talk and listening to me share how I approach a person or couple who comes to see me for the first time, whether it's a client or whether it's a patient, and how I lend my perspective, to that person and their situation, the history really matters, the goals really matter. And then, what do I think is going on under the surface matters. And using all those data points, I help bridge people to a successful outcome. So if you have more questions about this, I'm happy to record more content about, paradigms and how I think about people. If you want more tailored support on you and your particular journey and sort of what I think, I'm more than happy to do a consult to listen to you in your situation. But again, think about the principles we talked about. Sometimes less is more. Sometimes we don't need to rush to IVF. Sometimes IVF is the first, the next best step. But again, always interpreting in the context of you, your situation, your values, your goals, your desired family size. And that's usually when we can see the most empowered choices. So with that, you know how much I love you. Until the next time. Bye.
Thank you for listening to the Love and Science podcast. I'm so glad you joined us today. If you found this conversation valuable, if you could please rate, review, and share this podcast with your trusted people, it would mean so much to me. If you want more tools to help you navigate the fertility journey, please book a discovery call with me today. The link is in the show notes. Please do not let infertility have the final word. I'm here to take the burden from you so that you can achieve your goal of building your family. In gratitude, this is Dr. Erica Bove. I'm rooting for you always.